Hi, everybody. Welcome to today's webinar. I'm just going to give another, 10 seconds or so as we have a whole bunch of folks who are clicking in as we are now at the top of the hour. So we'll go ahead and get started. So today's webinar titled Persons with Lived Experience, Advice and Best Practices from Expert Peers. This is, again, part of our national series that we'll discuss in just a moment, focusing in on addressing diabetes within integrated care. Next slide, please. So if you haven't met me already, my name is Andrew Phillip. I'm the Senior Director for Clinical and Population Health here at the Primary Care Development Corporation. Next slide. And again, just a quick note about us. We, PCDC, Primary Care Development Corporation, we're a national nonprofit dedicated to really building excellence and equity within primary care, including associated areas like behavioral health. We do this in three ways: through investment, through advocacy work, and through training and consultation in a host of areas related to healthcare, including behavioral health and integrated care. Next slide, please. So we're going to do a quick poll here as we go through. So go ahead and tell us who you are. So do any of these match kind of your primary professional area? So do you work in outpatient primary care behavioral health? Are you in some sort of outpatient specialty care? Hospital-based or inpatient care? Are you part of administration or local leadership? Government, including state, local, and federal? Managed care? Academia? Working for one of the great aggregators of healthcare, like an independent practice association, ACO, or others, or something else. And I see folks are beginning to type in the chat box. Feel free to use the chat at the bottom of your screen there to type in what your area, what your professional practice area is, if it's not one of these. So we'll give just a couple more seconds. I know we've got a lot of choices for you to choose from, and then we'll go ahead and launch the poll results. We're getting a whole, I see we've got some folks coming in the chat. So by and large, 42% of folks are on that outpatient primary care and behavioral health world, followed up just by, it looks like, part of administration and leadership. We've also got a good number of folks representing government here, and also a good number of managed care payer organizations, which is really great to see. And then I saw in the chat there a number of others. So we've got consultants, we've got health insurance industry, patient-centered medical home program manager, excellent. Okay, great. So thanks everyone for being here. Today's work is really part of a partnership with SAMHSA and the Center of Excellence for Integrated Health Solutions, housed at the National Council for Behavioral Health. But it's important that we note that the views, the ideas, the opinions that we discuss today are not necessarily representative of the federal government, of SAMHSA, of the Center for Mental Health Services, Health and Human Services, or any other federal agency or administration. Next slide, please. This is part of our year-long conversation that is actually wrapping up today, where we really look at, how do we address diabetes within the context of both primary care and behavioral health, particularly within integrated primary care and behavioral health. And in doing this, we know that there's a few key areas that come up. We know that it's really screening and managing for diabetes, but also partnering with our patients as well as our interdisciplinary teams when available to do this. So we've been looking at how do we maximize the value of every person who's on the team, who's working with our patients. If we don't have expansive teams, how do we leverage the skills of you or whatever person is working with this individual to maximize what we're giving them? And as we talked about recently, amidst COVID, we know that access has gotten tighter, and it's more important than ever before that whoever you are, wherever you're interacting with a patient, that you're able to give them the maximum possible or connect them with the additional service that they may need. And then finally, looking at the processes, and that's where we spent the last 2 months of our time here, thinking about the processes. How do we maximize those to also make sure that we're accounting for the full range of needs? So next slide, please. So this is a run of what our series has looked like so far. So we went through, and actually, it's quite meaningful that Amy Walters, who I'll introduce in a moment, is here with us, because she actually kicked us off at the beginning of our behavioral treatment piece on here, talking about what is the impact of behavioral health providers. We've talked about everything from prescribing to bringing in the impact of nutrition, pharmacy, looking at pathways and procedures and sustainability. And it's clear that although we've talked about these different processes, what really ties this all together, what makes this matter, what brings in the human perspective is this last one here, persons with lived experience. So we've been building up to this. We have those kind of other structures in place, and this is where we're going to focus today. Next slide, please. So I think we've all pretty much heard this at this point, but again, if you're new, we're talking about diabetes and behavioral health because we know that they are intricately tied together in many different ways. We know that people who are living with behavioral health conditions are actually more likely to be susceptible to developing or having complications related to diabetes. And similarly, on the flip side, people with diabetes are also at a disproportionate risk of dealing with behavioral health conditions, things like depression, anxiety, or other conditions, and they can kind of commingle. So we know that we can't just look at these in complete isolation. And finally, we also know that there's numerous behavioral factors associated with both of these things. And so it's a great opportunity, particularly for behavioral health and primary care, where the majority of issues are seen, to address these jointly. And of course, think about our shared metrics. Next slide, please. So I'm excited to introduce our two guests today. So we'll be using an interview style format today, which is kind of a nice difference from how we've been doing so far. So again, you may have remembered Dr. Amy Walters. She's a clinical health psychologist and consultant and director of behavioral health services for St. Luke's Humphreys Diabetes. And she's joined us, and she provides expertise nationally, locally around addressing diabetes, around the topics of health psychology. And she's also on our integrated care faculty. We're also honored and excited to bring in Sarah Mart. Sarah is the Chief Operating Officer of Diabetes Sisters, who we'll be hearing about today. In addition to her operational work, she has a background in advocacy around looking at health policy and in bringing in higher education to really create strategic partnerships and broad initiatives to bring in health intervention initiatives. So we'll kick it off. And again, just kind of setting us up here, we're having a conversation with myself, with Amy, and with Sarah, really thinking about how do we bring in the voice of people with lived experience. I think all too often, and I'll admit, as a treating psychologist, I've been guilty of this myself. It becomes very easy, I think, for almost all of us to see our patients as their diagnoses, or to see them as the conditions we're working on them with. So, for example, in the case of diabetes, I may get a referral from a primary care doc, and basically, what do I see this person as? What do I see the referral as? Well, it's med management, or it's medication compliance, it's blood glucose monitoring, right? It's these kind of individual behaviors, or it's depression, right? It's that sort of diagnostic label. But we get the feeling that there's a whole lot more to the story. And so that's kind of how we're setting up the stage for today. So I think we can just move straight into our video slides here. And so I'd like to kick this off. Sarah, maybe you can start us off. Just tell us a little bit about who you are, what's your connection to diabetes and behavioral health, and maybe a little bit about Diabetes Sisters as well.
Sure. Thanks so much, and thanks for inviting me and having me on the panel today. It's really exciting to see what you all have been doing and to be able to be a part of it. So diabetes and also peer support, which is a primary goal and activity of what Diabetes Sisters does, have been important topics for me for pretty much my whole life, both personally and professionally. I was diagnosed with type 1 diabetes in 1980, and I was 7 years old, and I was the only one that I knew who lived with this condition for quite a while. I was lucky enough to attend a summer camp for kids with diabetes from when I was age 8 to 14, and then was able to work there as a junior counselor and counselor through undergrad. And that was, for every summer, the best week of my year, the best weeks of my life. And I would describe it then and still now as you know, for anyone who doesn't have diabetes, to imagine that you're an alien living on a planet of others not like you with your everyday life all the time, and then being able to walk into this camp and see 100 other aliens like you, kids and adults like you, and to have that be the normal. Instead of having to work so hard to try to do all the things that one has to do with diabetes and do that in, you know, someone else's normal. So it truly was amazing, and I'm still able to see and communicate with some of my friends from that camp today. Thank you, social media. And social media also played a huge role in me finding diabetes community again. When I was in my 30s, I spent, a decade or two, again, really without anyone else with diabetes in my life. And yeah, so that can be, of course, very lonely, but then finding others who get it, who understand what it's like to do any of the, 180 plus decisions that people with diabetes make every day and throughout the night as well, is really, truly fantastic and almost unable to describe. So I apologize for any lack thereof, but feel free to ask any questions along the way. And through the Diabetes Online community, I was also how I found and started working for Diabetes Sisters. So we are a national nonprofit. We are tiny but mighty, with 3 staff working full-time remotely in 3 different states. And I work with and oversee about 60 volunteer leaders who are located in 20 or more states across the country, and we're always looking for more. And these days, all of our peer support groups that they lead are online during pandemic times. But without the pandemic, we are doing in-person meetings as well. And we find and have found, one of the most common and striking statements that we hear from women who find us and start participating is that you've saved my life, you've changed my life. I can't imagine what it was like living without peer support and others who get it. This is the best thing. So that is why and how we exist. And the leaders are primarily peer support. We do have educational modules, which are really discussion topics along with current, credible, accurate resources for all the leaders and members. And then we really see our website, which has, a really high viewer rate and accompanying social media as supporting all of that and being there for women everywhere, women living with any type of diabetes, type 1, type 2, LADA or 1.5, as well as pre-diabetes too, because we're seeing more and more women contacting us and looking for support who have been, told they have pre-diabetes as well.
Thanks, Sarah. And just one quick, first of all, this is like inspiring. Even as you're talking about, you saved my life. Like I feel myself tearing up a little bit. This is incredible. For folks, just I'm aware we have a pretty diverse audience. Like you mentioned LADA. Can you just define what that is?
Oh, sure. Oh my goodness. It's essentially insulin requiring diabetes diagnosed in adults. So I'm sorry, I'm blanking on the latent auto, I'm sorry, I'm blanking on the, the acronym.
I was just, we were talking about that. And
Sure.
you might have the answer first of all, but yeah, so certainly like, people who have kind of gone for most of their life, right, without a diagnosis of diabetes, and here it is. Well, thanks, Sarah. So I'm going to come back to a little bit of like the experience of folks who are living with diabetes, but I do want to, Amy, can you give us tell us a little bit about who you are, particularly for folks who weren't in our or don't remember, gosh, it was like almost a year ago now, about your work and particularly your connection with diabetes. I think that's what we didn't get to hear so much about last time.
Yeah, absolutely. First of all, just let me thank you very much for having me today. And I feel really honored to be part of this panel and just really grateful to PCDC for offering this series. I think it's so needed and a really important conversation. So really excited to be here with this today. So my connection with diabetes is both personal and professional. I know in the introduction, Andrew talked a little bit about my professional background. But the way that I came to work in diabetes, I was a new graduate with a shiny PhD and met this great pediatric nurse who was looking for a psychologist to volunteer at a diabetes camp and had some interest and done some early work in children with chronic disease. And I'm very outdoorsy, and this was up in Idaho's Sawtooth Mountains. And so was really excited to get there and check it out. And just was so taken aback by the experience of, number one, just how significant the psychosocial factors were for these kids dealing with this chronic condition, and how much motivation and behavior change and kind of coping emotionally were a part of the picture. So I continued, I kind of fell in love with this group and this camp, and I continued to volunteer summer after summer and became the volunteer psychologist for the group. And then 7 years into my experience, had twins. And then 1 year later, one of my twins was diagnosed with type 1 diabetes. We have no diabetes in my family. It was just kind of this crazy experience, which really cemented my interest professionally in psychosocial factors and diabetes. And so several years after, I had a private practice at the time, and I was having children from camp who were often referred to me for treatment, and I would get these referrals, but they wouldn't show up. And so one summer I went back to camp and I said, I'm confused. I know you're struggling and you got a referral. Tell me why you won't come in. Like, well, I have diabetes. I'm not crazy. I don't need a psychologist. So there's this complete disconnect between kind of the emotional side and then the medical side. And I really felt an importance to bring those two together. So I was able to work with the clinical director of St. Luke's Humphreys Diabetes Center, which at the time we were an independent, and he agreed with me. And I said, what would you think about us doing an integrated behavioral health program? So that we can just support this and make it part of the treatment, that, you're going to work with the CDE educator, you're going to work with our dietitian, you're going to see your physician, and you're going to see our psychologist to deal with the psychosocial factors inherent in diabetes, both type 1 and type 2. And we started 1 day a week, and it grew to a full-time position. And now I have an additional full-time clinical social worker who's part of my team. And we're looking to hire another person because it's catching on and people are realizing, wow, yeah, we just do a lot better if we can support this. And I continue to volunteer at camp. I've been part of that camp staff now for 23 years. And as Sarah was talking, I was just getting goosebumps hearing her about her camp experience, because I really do feel like the very best psychosocial intervention we have is that peer support. It is so normalizing. It is so important for people with diabetes to feel that connectedness and that motivation and that ongoing support that comes, because this disease is a marathon and it's exhausting, and having somebody else who gets it and can be there with you is just tremendous. So yeah, great topic, great conversation.
Thanks, Amy. Yeah, the camp piece and that making this real and human, you're right. I think that really speaks to a lot of folks' experience. And speaking of human, so Sarah, can you tell us a little about like a day in the life? If for particularly for an adult who's got diabetes, I think a lot of us here, again, we know about what medications are often prescribed. We know about the different a little bit about as far as the monitoring goes, but tell us a little bit about, like, from when you get up in the morning to when you go to bed, what does life actually look like? What are the things that someone with diabetes may be thinking about?
That's an excellent question. Like I said a moment ago. Oh, and first of all, I just have to say, so the LADA thing. So latent autoimmune diabetes in adults. So essentially what I was bumbling around about, but thank you to the folks in the chat, and I put it in there as well. So so there's that. But anyway, a day in the life of diabetes is, like I said, they've done a few studies, and I would be thrilled to see even more, and so interested in, more than 180 different decisions that everyone with diabetes is potentially thinking about at any moment in time. So from the moment I get up and the first thing I look at is my phone, because I'm privileged enough to be able to have, diabetes technology that communicates with my phone. So to look and see, how am I doing? Where am I right now? Like, there's a lot of feeling around everyday events for everyone else, getting up, getting food, getting family ready, going to work, while you're at work, but thinking, always having something else running in the back of your head in terms of physically what's going on with my body, mentally, how is that affecting what's going on for me? What am I supposed to be focusing on right now? And at the same time, you know, is my prescription out of date? Am I going to be able to afford the medicine that I need? And what are we going to have for dinner? And how many carbs is that going to have? And, you know, am I going to walk before or after dinner? And, you know, in the days of the virus, where am I going to fit in, you know, activities such that I'm not around others, or where's my mask, you know? So, so it's almost like the COVID is just another layer on top of this never-ending, you know, layer or bubble that surrounds folks with diabetes. And I'll just say too, like the types of things that we absolutely must have to, you know, attempt to manage this chronic condition in terms of medications or, you know, healthy food, different types of food, the ability to go outside, to exercise, or exercise inside. Those are things that maybe others without diabetes can, you know, just make the choice to do, but for us it has to fit in with everything else, with our lives and with what's going on with this this condition at that moment in time. And another thing, it's interesting to think about the difference between the day long, every day, as well as everything that we're doing or not doing, coming to a conclusion that would be invisible, essentially. So if we don't get any complications, which incidentally, not 100% of our behaviors are going to, you know, some of it we can't control in terms of whether or not various complications come up for us. But if we do a good job, we won't see that, right? We won't see the negative effects. So it's essentially ongoing, eternal prevention that we don't necessarily get any good gold stars for, or you know, certificates.
That's such a great point, and I think that really goes unseen. You know, you know, like a lot of us have behavioral backgrounds, and I think we know like how reinforcement works. And when you have no feedback whatsoever, really, other than just occasional bad feedback when something goes poorly, it's like, it's pretty hard to reinforce that behavior. And it just, I imagine, adds to like the planfulness that you were describing, that the great level of intentionality that goes into everything from, like, you know, when you're first grabbing your phone in the morning to thinking about, you know, what's for dinner tonight, what's for the family. And it's not just what am I in the mood for, right? Which I think is kind of what a lot of folks think about, but it's going into the calculations, planning ahead for then, right? Like what do you have to have with you? You know, obviously we're talking about different forms of diabetes in this conversation, but right, like are we considering bringing insulin or taking, you know, different medications orally? So I can see how those things coming together to be, you know, what sounds like a tiring experience, a really exhausting kind of thing. And I, you know, I assume some of it sort of becomes a little bit automatic after a while, but it sounds like there's still, no matter what, there's this level of thought and intention you have to put into managing it that can be tough.
Oh, for sure. And both, like you said, the invisibility of it can lead to, you know, and maybe the reality that we are the only one that we know, or it may feel very lonely. And I would also, something also came up as you were saying around the feedback. You know, I grew up personally in a very rural, in Montana, a very rural area, and I, as a child, as a 7-year-old, went to a lot of diabetes education classes with adults because that's who was there, who needed diabetes education as well, and a lot of type 2. But the messages I've heard others have lived with across the country or around the world are similar as well, in terms of constant talking about the complications and relating them to, if you don't do X, Y, or Z, which is what you're being instructed to do and being told to do and being prescribed to do, there will be these bad consequences at some point. So you know, potentially quite fear-based, well-intentioned, hopefully, but you know, telling a kid or a 25 or 30-year-old, you know, you don't want to, we don't want to have to cut off your foot. I mean, those are the types of messages that many of us with diabetes have heard, and sometimes many times. And I think about how different that is from just, for instance, and you know, one example of being able to go potentially online in the middle of the night because your blood sugar is super high and you've done everything you can to think, you know, to attempt to get it down, and it's still super high and you can't go to sleep because you don't feel well, and able to get into a conversation with 3 other people in other states and other countries who are dealing with the same thing, or who have been there and can say, yep, and you know what, let's chat about whatever, and until you can check in an hour and again and see how it goes. I mean, there's just something so amazing about being around or hearing from someone who gets it. And it totally contributes and can contribute to, you know, being able to take medicine as prescribed and being able to follow various suggestions and recommendations for, you know, healthier behaviors that are super hard to do on your own.
Yeah, the isolating component of it, I could see how it'd be so powerful, you know, having folks who really get it, you know. I want to come back to this, but for a moment, just, you know, you talked a little bit about some of the experience I thought that was so powerful when you talked about, you know, going to the classes as a child and you know, being around all these adults, because that's kind of who they were, you know, a lot of them were designed for. I know that the experiences of children and adolescents are their own, you know, pretty complicated animal. So Amy, maybe can you talk a little bit about you know, about being mom and kind of about what that experience has been like?
Yeah, absolutely. And you bring up such a great point, Sarah, because one of the things that I like to think about and talk about is that the challenges of diabetes really vary by developmental level, and they keep coming back. So you may have kind of figured it out if you're a parent of a toddler, and then you get into school age and it's like, oh, things are very different now. So for example, with my daughter who's diagnosed at age 1, as an infant and a small child, eating habits are a big deal. We were dosing insulin based on what she was eating. Well, 1-year-olds don't eat 3 meals a day. And we were needing to test her blood sugar and monitor for symptoms of hyperglycemia or hypoglycemia, and yet she couldn't tell me how she was feeling. So that resulted in multiple monitoring. So this was before the days of the continuous glucose sensors. And so we were poking this baby 10 to 12 times a day to test her blood sugars, see where she was. Each time she would eat, she would need insulin. And our provider said, well, you're going to have the best control if you dose her insulin before she eats. So as a diligent mom, I'm pulling up the insulin and dosing my 1-year-old who has this plate of food in front of her. And then she says, done. What do you mean you're done? Like, you have the insulin, you need to eat, or your blood sugar is going to drop quickly. And yet she wasn't going to eat. So that presented one set of circumstances. You move into school age, and as a parent, maybe you've worked with a daycare provider and you're working really hard and you've got a system down, and now this baby of yours is 6 years old and needs to go to school, and now you need to work with a school nurse, and they're not going to be under your direct control anymore, and kids want to do sleepovers, and how does that work? And what about birthday parties at school? Do we let them have cake with the other kids so that they can feel a part of things? But what if your blood sugar is 300? That's not such a great idea medically. So you start to see this in between of kind of what's best emotionally and what's best medically. And sometimes those things line up nicely, and sometimes they couldn't be further apart. You move into teenage years and you have issues with dating and drinking, and oh, I've got this great prom dress, but where do I put my pump? How does that work? So, you know, each developmental level, we have these different issues that come into play. And can we pull up the one slide that I included for us in today's presentation? Because I wanted to kind of tie this back to some things that Sarah was saying. we focus so much as medical providers on the physical part of the disease. And so that's right there at the center for you. But we have all these other areas. And when I put this slide together, I use circles because it's really like you're juggling all these balls. I have all of these balls that I'm supposed to be keeping in the air all of the time. And if I don't keep them in the air successfully, bad things are going to happen. And yet it's really hard to manage all these balls every single time. So, we have all these different areas, the financial piece. And I love what you said, Sarah, about you have the privilege to have some of the technology, because the technology can be fabulous. However, the technology is expensive. And even as someone who has a great insurance plan, I just picked up my daughter's CGM for the next 3 months, and my out of pocket was $500. That's just for her CGM. That's not for her insulin. That's not for her backup testing supplies. That's not for her pump or pump supplies. So you get this inequity that occurs very quickly, especially for some of our patients who struggle financially. And that can be a big barrier to treatment. So we always want to make sure that we're including in that conversation, how are you doing with the financial piece of this? There's this emotional toll, which Andrew mentioned a minute ago. When it comes to the anxiety and depression, there's a lot higher rate of prevalence. And as Sarah was mentioning, this is a disease where you're avoiding bad things. It's like, I don't want to deal with, I have to do all these things so that these bad things don't happen. And I often see patterns of avoidance in people because it just becomes overwhelming and they don't feel very successful and it's distressing. So let's just stay away from it. There's this social toll, as I was referencing, with like birthday parties and sleepovers and dating. And what about when you're looking for a mate, and how is that going to play into things? And how does it work with my friends when everybody else is getting together because they're having a party despite COVID, and I have really high risk factors, and I just don't know if that's a good idea for me to go as a person with diabetes or as a family member of someone with diabetes. And what does that look like? So again, all these areas of impact that we want to be thinking about as we work with people.
Yeah, it's immense, and I love the visual that you've given us here. Like each of those things would often be like the only thing that we may opt to talk about with one of our clients or patients, right? And so thinking about this full spectrum, right? It has touch points in so many different areas of life, and then I think from what you described, like we hear it. It's not it's not just in the case of like a child, for example, or someone that you're caring for. It's not just there's their experience, but then also the caregiving part. And I remember, in past conversations talking about like, dealing with that in the middle of the night, and I think being not only mindful, so it's not just the individual being mindful of their experience, it's those who care for them, and kind of the same level of like worrying and similar experiences.
And really the opportunity to intervene, within that whole system. So we can help provide support for people with diabetes by looking at each of these areas. And I think the family piece or the peer piece is often overlooked. How do we help pull in those support people that they have and really have some nice communication about what is helpful, what's not so helpful? How does a family member feel empowered to be a good support without being a nag about exercise, without becoming the food police and making a bunch of comments that aren't really helpful? So, we're so fortunate at the Diabetes Center to have this multidisciplinary team of people who can really help. But even in the primary care environment, we can pull in our behaviorists, we can refer out if we need to, and collaborate with those individuals to help really create this nice support system in addressing these different areas.
Amy, as you're talking, you're reminding me of our, so over about a year ago, Amy and I were at a conference, and we had this conversation around like this idea of like a day in the life with diabetes. And Amy, do you mind if I share this photo that
Oh, you're very welcome to do that, yeah.
Hi, can I share my screen for a second? I just want to show everyone what's kind of going on here. Okay, so I'm gonna. So actually, I pulled this up on my Twitter account. That's where it was posted. So, selfish plug here, but so this was back April 27th, 2019. And so this was the photo that we'd taken here. And Amy, you had brought this kit with me, and you were showing me like all these different components. And this was just like this is a day carry on. Can you like kind of like highlight for us like what are the things that we're seeing in this photo?
Yeah, absolutely. So let me just scoot over. So I do a lot of professional talks around diabetes and psychosocial factors in diabetes, and started recognizing just how important it is for people to actually get it and get their hands on things and see things. And so, in this picture, you've kind of got daily supplies for a person with type 1 diabetes or a person who's insulin dependent type 2 diabetes. So we've got our glucometer there where we're taking, poking the finger and checking and taking blood sugar to see, that's our monitor to kind of see where things are. Many of the people I work with talk about this being a report card. They see that number and they feel like a good person or a bad person. So, oh, my number's in a good place, my number's in a bad place. So, just even the psychological piece of that, as opposed to, this is just a number that's telling us where things are and what we might want to do. So a number to kind of inform treatment. Up in the left-hand corner, you'll see that red box. That's glucagon. So glucagon is an emergency kit that we use. It's an injection that we can use in case somebody's having a bad low where they're not responsive and are unable to eat or drink something. That's an injection. It's now sub-Q available. It used to just be IM. And I guess my caveat to this is, having a 1-year-old and trying to talk to a babysitter about how you might have to give this child who's starting to seize an injection like this is kind of a game changer when it comes to finding babysitters. Other things you see there are an insulin pump. So that's the little device that's can then administer insulin more like a pancreas does. So throughout the day, every few minutes, getting little doses of basal insulin. And then the individual still has to add in what it is they're going to give for their bolus to either correct their blood sugars or to dose for their food. And then the pink round containers are infusion sets, and that goes with the insulin pump. So that's a device that's placed subcutaneously, replaced every 3 days, and insulin is administered through that little tube. So with this, I was just sharing with Andrew, these are some of the things that we talk about and our patients with diabetes are dealing with on a regular basis.
Thanks. Yeah, that experience always stuck out to me, right? Because even when we look through and we sort of, and again, like a lot of us, and I had treated patients with diabetes for years at this point, but really sitting down and using the actual buttons on the pump, looking at the small calculations that you have to put in there, it's remarkable. It's so much, there's a level of complexity to it that I think is hard to appreciate until you really kind of see it and go through it. And perhaps that's one kind of piece of advice we may give to folks in the audience. And actually that's where I'd like to take us to now. And Sarah, maybe you can kick us off, so thinking about the folks who are in the room right now, how do we translate this into the clinic? And we'll talk about peers in a second, but particularly for clinicians, for clinic leaders who may not have their own lived experience around diabetes, what should they know? What should they take into account based on what we've been talking about so far?
Oh my goodness. Excellent question. And I think as far as being just right now at this moment for me, just being a person with diabetes and an adult who's lived with diabetes for quite some time, I would say that you don't have to know it all or do it all or feel like you have to in order to, first of all, be inquisitive and be curious about exactly that question, what life is like for your patients with diabetes. I think being open to that and even, having some type of meeting at some point where you invite some patients in and ask them to tell you about what their lives are like, what challenges they have, this of course can be with both men and women, but for those who can and want to dedicate that kind of time to that, I think that can give you so much. And especially if, no one on your staff or no one that you work with lives with diabetes. I mean, that's another even further back question, is to find that out. I would also say, in terms of Diabetes Sisters, of course, we are a wonderful resource and we have tons of wonderful resources online, so accessible to folks. but also find out about that locally, and see us as that, see the people, the loved ones, and or, maybe they aren't family or friends, but they are others with diabetes that your patients may communicate with or may, lean on each other. Find out where they are and how you can make a referral to peer support networks in the community, and know what's online, and feel okay about talking about that with your patients as well.
I appreciate that, and that point of feeling okay talking to your patients about these things, and just I think having like these honest conversations, like that's where important things happen. Amy, I'm thinking about some of the work that you do at St. Luke's, and I'm wondering, specifically like for the primary care set in the audience where, they're used to, maybe I have like 5, 10, 15 minutes with the person who's before me. How do we connect? How do we bring in their experience into the room? What are some things that you've done?
Yeah, it's such a great question because, just like everything with diabetes, there's so much that we could do. How do we do that in a brief period of time? I guess a couple thoughts. One would be, first, just checking in with that individual, saying, we have about 15 minutes today. What would be most helpful for you? Which area are you struggling the most with? And how can I support you in that? I use a lot of motivational interviewing in my work with people with diabetes, and I think it's really helpful. It's about being that good guide. I know a lot about behavior change, and I'm an expert in that area, but you're an expert in you. You're an expert in your diabetes and what's working and what's not. So let's start there. I think really thinking about those different balls and trying to identify, and sometimes I'll even use that with patients if they're feeling a little overwhelmed. I may just pull that out as a handout and say, there's all these different areas that are affected by diabetes. Is there one of those areas that you feel like is the biggest struggle today? Because, for example, if the finances aren't working, if I can't afford my medication or my test strips or can't afford food this month, you can talk all you want about some of these other things, but it's just not going to matter. We need to meet that basic need and figure that one out first. And so really being wise about the way that we're spending that time and really letting the patient guide that. The other thing is, I think that it's always important, and this goes along with good motivational interviewing as well, to really acknowledge the positives. So many people with diabetes have negative experiences in provider appointments because their providers are doing their best to try to problem solve the issues. And yet the person on the other side is like, I'm working really hard and I don't feel like you're seeing any of that or saying any of that. You're focusing in on the numbers that aren't where I want them to be, when look at all these ones that were great. So we want to make sure we're really acknowledging all of the positives, all of the hard work, and then problem solving together what we can do next.
Yeah.
And then using just behavioral strategies.
I would just add to that everything. Well, yes, everything that Amy just said, but add the specifics around. I have had some really amazing primary care experiences where, they, first of all, they recognize, they say, I see that you have diabetes, whatever specifics, but then is there anything I can help you with that? Are you seeing anyone else for it? But regardless of what my answer to them is with that, they will say, like, is there anything I can do? Or, what about this one thing? But not like we have to make that the focus of the appointment. It generally isn't. I'm there for whatever other things, but it's a wonderful, both open but specific question around that specific appointment that lets me be seen. And also, if I did have something that I needed their help with, they open it up to that.
Yeah, no, that's yeah, I love that idea. That's again, coming back to the idea of being seen, right? I'd like to talk a little bit about, and just for everyone in the audience, we're gonna, I noticed a number of you have been entering some questions in. We're about to transition to questions in just another like 5 or 6 minutes, so keep them coming. And just as folks are kind of entering in their comments and questions, maybe you can kind of start us off. I want to talk a little bit about, obviously we're kind of hearing about generally, but can you talk specifically about from your vantage point, people with lived experience, and particularly like, I know we also throw around these terms like, and Sarah will talk about this too, I think, like peers, persons with lived experience, peer support specialists, sometimes people mention diabetes educator, like, can you talk about some of the roles and particularly how you have incorporated folks with experience into your work?
Yeah, absolutely. So I'm fortunate enough to be part of a diabetes center that's got a fantastic team of people. Many of our medical providers have type 1 diabetes. Many of our diabetes educators have type 1 diabetes or type 2 diabetes or have family members. So they can incorporate that as well. And I think anytime we've got that element, it's always a helpful support. So we've got kind of our formal professional team. But then we also have this great community of people. And I think Idaho is really fortunate to have a fantastic group, definitely within the type 1 area. We've got Idaho Diabetes Youth Programs, and that's part of the Camp Hodiah, which is part of this camp that I've been part of for years. So yes, we have a summer camp that we try to get kids to, but there's also a number of other activities that happen throughout the year. There's a whole network of individuals who are part of that. And so one of the things that we try to do is connect people, either in our community specifically, using online communities so that they don't feel alone, so that they do have additional resources. And then we try to pull in family members, close friends, anyone who's going to be a support for them in their lives, and teach them, how do you use that support system? How do you communicate openly with that support system? How do you set boundaries sometimes with that support system to kind of let them know what's helpful and what's not helpful? But just acknowledging, and we know from the literature that people who have a strong social support system just do better in the long run with diabetes and with all chronic conditions.
And Sarah, I know that Diabetes Sisters, this is what y'all do, and you've mentioned a few different formats, and I know it's some of them are meant for certain populations, some of them are meant for like you mentioned doing it remotely, which I think is suddenly, you've been doing this for years, it sounds like, but suddenly this is like, whoa, this is on everybody's radar. So maybe you could talk a bit about that, and again, kind of going into some of the roles and how people kind of interface with care.
Sure. So as I said, and you've mentioned, we are all about the peers and the peer support. So Diabetes Sisters is for women age 18 and up who, like I said, live with any type of diabetes. We also, so our collaborations and partnerships kind of go in the same but reverse direction, I guess, outward to clinical medical communities, certified diabetes educators, nurses, dietitians, endocrinologists, etc., in terms of a lot of the content and really balancing and sharing both, the clinical expertise, medical content with, again, people with lived experience and their expertise. I frame it in other talks that I give a lot of the time as lived expertise because it's not just experience. If you're living with this condition, with this disease, as with other chronic illnesses, we're experts in our lives, right? So so it's really quite wonderful, I think, in terms of, like I said, our website, which we've been building and has gone through, multiple renovations over the years, but Diabetes Sisters has been around for the last 10 years. So, and then again, like I said, in terms of the in-person peer support groups, we also, for about the last 5 years, have been doing what we call our minority initiative, which is specifically focusing and reaching out to Black, African American, Hispanic, Latina communities, as well as South Asian communities in a variety of locations. It has been around the US, but then in the last 6 months, it's been online as well. So we were doing in-person community education and support events. Now we have videos. We've taken the same speakers and leaders that we would work with on the ground, and we've just started posting 30-minute videos on exercising at home when you can't get out for whatever reasons, how to cook healthfully and cook in ways that work for both ourselves as diabetics as well as, other members of our family with whatever we've got in the pantry, right? So again, it's really practical, on the ground living with diabetes, and we're able to share those videos, widespread, as well as with patients in the specific clinics where we would be in real life. and hopefully will be soon again.
Hopefully. I mean, that's really, I think that's really refreshing and great to hear. Not only that you're reaching people who, you know, geographically or from just a resource perspective, transportation otherwise would have so much trouble accessing it. But you know, I love that you highlight, you know, particularly Black women, women of color, indigenous populations, and others. We know that there's disproportionately, you know, high rates of not only just diabetes, but like then the complications and, you know, even mortality related to this. And so, you know, amidst our, you know, multiple pandemics, including that of racism, I'm really happy to hear that you're, you know, you're naming that and that you're doing this work as well. And I know others in the room are too. So I want to open it up. I'm a little bit selfish and I would keep going, but I want to open up to, I know we've gotten some questions. My colleague, Kristen Potterbush has kind of been tracking some of that. And so Kristen, I'd invite you in. And Chaim, maybe while we're doing this, because I know we're going to run out of time, if you can pull up some of the contact information for Sarah and Amy. And also so folks know this and the entire 7-part series, most of it's already up, and then today should be up later this week, is going to be available at pcdc.org/diabetes series. So if there's any resources that you missed or anything else that you want to see or the recording for today, you'll see that, and we'll send it out to everyone by email as well.
Well, thank you, Andrew. And I think, you know, something that we're seeing echoed throughout the comments is just how powerful and important that this conversation is. And so I think one of the first questions that I sort of want to bring out that we're seeing sort of themed here is how to respectfully, as a provider or as an educator, have this conversation with an individual who's living with diabetes, sort of around the day-to-day of taking care of themselves and making sure that folks can live into what is their most healthy life. And, you know, sort of going back maybe to what Sarah said around, you know, letting folks be their own experts on what they're living with. So I think that there would be a lot of interest in hearing guidance that the panelists today would have around how to have this conversation as respectfully and as meaningfully as possible with individuals who, you know, you're serving.
Absolutely. I'm happy to jump in, and then Sarah, you can piggyback.
Sure.
So I think, first of all, just always acknowledging the individual. How are you? How are things going? What's going really well for you and what maybe isn't going so well? And then sometimes it's hard to know where to start. And so using a graphic like the one I shared, or in motivational interviewing, we have what's called the bubble chart, where you kind of take a piece of paper and you make some little circles and say, well, you know, we've got activity and we've got eating habits and we've got kind of emotional health, we've got family conflict, we've got finances. There's lots of areas diabetes are touching on. So is there one of those areas that would be really helpful for us to work on today and kind of focus on for you? So kind of presenting this menu of ideas and then letting the individual steer you where they'd like to go.
Yeah, I would totally agree with and say that the type of thing that Amy just described is really powerful. I mean, first of all, acknowledging that, you know, as a provider, that we have all the balls on the chart and more, all up in the air, and also being able to acknowledge that whatever diabetes goal or whatever diabetes thing that the provider may want to talk to me about at that day may not be the top #1 thing on my priority list. So being okay with that as a provider, if you're going to ask that type of question, and again, knowing that appointments are potentially so short and everything can't be covered. It's really powerful to hear, well, you know, we don't focus on that here, or that's not something I have expertise in, but I know about this. And would you like, you know, this person's name or contact info or link to something? It's really powerful and huge. And I would just say, especially with the populations that we work with so much, we talked a lot earlier about children and younger people perhaps, or caretakers and parents, but as women with diabetes, there's even so much that isn't known as far as hormones and their effect and what's going on with other parts of our clinical medical selves that we bring to the office, and acknowledging that along with us, like perimenopause, menopause, a lot of attention sometimes is paid to pregnancy, and which is wonderful and important, but at the same time, as we're getting older, and there isn't a lot of research on that, or when something new comes out, it's exciting and new, and sharing and being able to talk about that, again, comes back to the being seen and acknowledging that, that we're working hard.
Thank you both so much for speaking to that. You know, I think that that acknowledgement piece, and also, you know, what you were sharing a bit earlier about, you know, all of the other factors that someone brings when they come into a provider's office is a great segue to another topic that's getting a bit of conversation in our comments, which is around this sort of emotional well-being, social development, developmental milestones component. You know, this broad series is really, you know, about integrated health. So I'm wondering, you know, Sarah and Amy, if you could speak a little bit more towards shining a light in what folks who are providers on the call today can do to shine more of a light on this intersection between behavioral and mental health needs, concerns, experiences, you know, for an individual or client who's living with diabetes.
Sure. So maybe even just normalizing, I think, is one of the most powerful things you can do, and just recognizing and saying out loud, you know, this is a lot. This disease is tough to manage. Burnout happens all the time for people. And we want to take care of the whole person. We want to make sure that we're addressing your emotional health as well as your physical health. And you're all one person. And so it's not about, oh, you now have a mental health diagnosis. It's about, let's treat this whole person and everything that this disease you know, brings about for them. So really kind of normalizing and then validating when those issues do come up. This is hard. And I guess the other point that I would make with that, Sarah made a comment, you know, you've kind of got all your diabetes balls, but then you have all the other things, like just being a middle-aged mom who's taking care of your children, who's taking care of aging parents, who's trying to navigate COVID and maybe do some at-home education. And, oh yeah, I have diabetes and I probably need to take care of that too. So you have all the additional developmental things going on, whether it's somebody in midlife, somebody who's older age, somebody who's in adolescence, all the challenges of those things, plus diabetes layered on. So I think it's always a nice avenue to just talk about, you know, somebody in your age group might be struggling with some of these things. How's that working for you? And how then does that dovetail with your diabetes?
Right. And I would say too, so for any behavior or any type of self-care, self-management item that we or our providers may want for us to do more of, do better of, increase. For every one of those 180 plus decisions in the day, there are more than 45 factors that could potentially be affecting that one thing. So I see a number on my meter and or my CGM, and there are potentially, you know, more than 45 things that I could do something about, maybe perhaps that might have a positive effect on that number, or it might have an effect, but it may not be positive or whatever. So, and I'm thinking about that in the middle of 20 other life things that aren't diabetes related. So acknowledging that, recognizing that, along with the fact that, I mean, as we've said before, you know, in various studies, it's called cognitive burden or complexity and diabetes. And that isn't, like, we don't set aside a specific 20 minutes out of each day to deal with that. Like, that's just ongoing all the time at the same time as everything else. So, and I liked what I think Amy said earlier about focusing on the positive, and that is kind of couched within all of the things that might sound harsh and tiresome and troubling about diabetes life, is that we actually, with peer support and Diabetes Sisters, work really hard on thriving and talking about thriving with diabetes, and as well as surviving, and focusing on what went well. It's wonderful to have someone who understands that as well. Like, I did the same thing that I've been doing for 5 days that has not had the positive effect for 5 days, but today I got the outcome that I wanted, in terms of my blood sugar or what have you. That's fabulous, and to be able to share around those things is wonderful as well.
Yes, I'm realizing, Kristen, you're probably very aware that we have a ton of feedback in the comment sections, and overwhelmingly, in addition, like, people have there's many more questions, and Amy and Sarah have agreed to this ahead of time, but feel free, you have their contact information there, you can keep the conversations going. But, it sounds like just across the board, remembering like that we're human and having a human conversation with somebody, asking what matters to them, finding out like, why are they even here? It's not just because they have an appointment to check in on their diabetes, right? There's some reason why they're actually going through the effort, sloughing into the clinic or getting on video. There's some reason why they're monitoring their blood sugar. Like, what is that? And can we connect with them around that? And then acknowledge, right? Like, I love that you've both pointed out, like, acknowledging these other areas of life. And I think as we're all patients, right? Whether or not we have diabetes, and I'll say from my own experience, like, I sort of go in with a set of expectations of what does my doctor want to know about me? What do they care about? Whether it's informed or not. And I'm not going to go in with all this other stuff, but it's so disarming when someone like acknowledges this other aspect of my life. It's almost like, you almost get emotional. It's so meaningful to just be acknowledged as a person, as human. Well, so we're at the end of our time already, and this has been such a great conversation, and a really, really, I think, important and just enriching way to end our year-long series here. So Amy, Sarah, and of course working away here is Kristen and Chaim behind the scenes. Thank you so much for taking the time and for sharing these experiences with us today. And much more, and on a broad level, thank you to everyone who's been coming to our series, to SAMHSA, to our Federal Substance Abuse and Mental Health Service Administration, and of course, to the great folks at the National Council for Behavioral Health, who is the home for the Center of Excellence for Integrated Health Solutions. So again, you can check out this recording as well as our full series at pcdc.org/diabetes series. Or you can also check it out at thenationalcouncil.org, along with a host of other resources from the Center of Excellence. So thank you, everyone. Any parting words, Amy or Sarah, for our folks here?
Go ahead, Sarah.
I would just say, is it possible to show the little Diabetes Sisters slide?
Yes, you have that.
Just for a moment, might be kind of fun.
Yeah, and we're also going to have this up on our website there, so folks can see that too.
Oh, awesome.
But, yeah.
Yes. I would just say thank you. Thank you to the, almost 200 folks who have been with us this last hour. And even though I can't see you or interact with you, I really value that you took the time to be here. So thanks for having me.
Yeah, and I would echo that. It's such an important conversation. Thrilled to have so many people participating. Diabetes is a condition that brings so much mental load, so much fatigue. There's a lot of guilt and shame. So as providers, we really have an opportunity to build that hope and optimism, to help people with their problem solving, and just let them know they're not alone, connect them with that community so that they can continue to have that motivation, that drive for good health and good care.
That's great. And Sarah, we've got the Diabetes Sisters there in front of us. Is that right?
Yes. From a variety of locations: Richmond, Virginia, Bridgewater, New Jersey, North Carolina. Yeah. Oh,
that's so great. Okay. Well, I've broken my own cardinal rule of not usually going over, but I really appreciate all of you, and thanks everyone, and again, thanks to our audience. Keep in touch. We have some exciting news coming out soon about what the following year holds. And obviously it's a meaningful conversation. Let us know what you thought. If you like this format, I know we kind of mix it up between webinar style, some interview conversations, case presentations. So keep us posted. But we definitely look forward to following the work of Diabetes Sisters, Amy, your work at St. Luke's, and also just all over the place. So let's all keep in touch. Thank you everyone for joining us again. And with that, we will wrap up. Thanks everyone.
Bye. Thanks everyone. Bye.